Chapter 15, we're going to deal with the autonomic nervous system and the visceral reflexes. Now, we've already covered the various subdivisions of the nervous system, such as the CNS and the PNS. And now we're going to cover the autonomic nervous system, which is a subdivision or another division of the PNS. And of course, in all the subdivisions that are involved in the autonomic nervous system. Within the lecture, you hear me refer to autonomic system as the ANS. So please keep that in mind as we go through. So the autonomic nervous system can be defined as a motor nervous system that controls glands, cardiac muscle, and smooth muscle. It is also called the visceral motor system to distinguish it from the somatic motor system that controls the skeletal muscle. Now, its primary target muscles are the viscera of the thoracic and the abdominal pelvic cavities, and some structures of the body wall, including blood vessels, sweat glands, and pyoerector muscles. When we refer to the visceral motor body, we're looking at organs in the cavities of the body, especially in the abdominal cavity. Now, the ANS, it usually carries out its actions involuntary. So that's without any consciousness or awareness. Looking at, for example, our blood vessels with a change size with vasodilation, vasoconstriction, even when our heart is beating faster. That's involuntary control. Now, the visceral effectors do not depend on the ANS to function, but only to adjust their activity to changing needs. Now, if the ANS needs to cardiac or smooth muscles, if the ANS nerves to the cardiac or the smooth muscles are severed, then the muscle is going to exhibit exaggerated responses, and that's what is called the denervation hypersensitivity. Now, the ANS is responsible for visceral reflexes, and that is unconscious, automated stereotype responses to stimulation, much like somatic reflexes, but involving visceral receptors and effectors. When we look at the visceral reflex arc, we have certain things that are come into play. We have receptors, we have afferent neurons, we have interneurons, efferent neurons, and effectors. Now, the effectors, they are nerve endings that detect the stretch, the tissue damage, blood chemicals, body temperature, and any other internal stimuli. The afferent neurons, they're the ones that lead to the CNS. Then we have the interneuron, which is found within, or that lies within the CNS. Then we have our efferent. Those are the ones that carry the motor signals away from the CNS. Then we have our effectors, which are going to make the adjustments so that we can make the proper response. Now, an example of someone suffering from high blood pressure is an example that your book gives for figure 15.1. And we're going to look at the various activities that occur with the visceral reflexes. Now, if a person is suffering from high blood pressure, it's going to be detected by these various baroreceptors in the carotid artery, the common carotid artery, and of course in the aorta. Now, these signals are transmitted via the glucopharyngeal nerve to the medulla oblongata, found right here in the brainstem. Now, the medulla is going to integrate the information and then send signals via the vagus nerve back to the heart. And these signals are going to slow the heart down so that it can reduce blood pressure. This is an example of homeostatic negative feedback loop. So when you get a chance, make sure you go over the few steps, what happens with a homeostatic negative feedback loop. Now the ANS has two subdivisions. It has a sympathetic and a sympathetic and a parasympathetic division. Now these two divisions often innervate the same target organs and have cooperative or contrasting effects. The sympathetic division, it increases alertness, heart rate, blood pressure, pulmonary air flow, blood glucose concentration, and blood flow to muscles, while reducing blood flow to the skin and the digestive tract. The parasympathetic has a more of a calming effect on the body's functions, and it's associated with reduced energy expenditure and normal bodily maintenance. So we're going to look at it as the resting and the digesting state. Now normally both symptoms are active spontaneously, exhibiting a background rate of activity called autonomic tone, and that shifts from one to the other depending on the individual's needs. Now either division has universally excitatory or common effect. So when we look at the parasympathetic tone, it's going to maintain the smooth muscle tone in the intestines. Then it holds the resting heart rate down to about 70 to 80 beats per minute. But the parasympathetic, it keeps most blood vessels partially constricted and maintains the blood pressure. Now the sympathetic division of the ANS hold on a second. Okay, so in terms of the neural pathways, the ANS has components in both the CNS and the PNS. The ANS includes nuclei in the hypothalamus and other brainstem regions, motor neurons in the spinal cord, and the peripheral ganglia, and nerve fibers that travel through the cranial and the spinal nerves. The autonomic motor pathways differs significantly from somatic motor pathways. In the somatic motor pathway, a motor neuron in the brainstem or the spinal cord extends a myelinated axon all the way to the skeletal muscle. But in the autonomic pathway, the signals travel. The signal must travel across two neurons just to reach the target, a gland or a smooth muscle cell, and must cross synapse where these two neurons must meet in the autonomic ganglion. So let's take a look at this diagram. Here we have the somatic pathway, and we see that it's just one motor neuron from the CNS to the particular target muscle. But with the autonomic pathway, you're going to have two neurons, which will have, one will be our preganglion neuron and our postganglion neuron. And of course, it must cross the synapse where these two neurons are going to meet, and they're going to meet in the autonomic ganglion. So in this first neuron, the preganglion neuron, it has a soma in the brainstem or the spinal cord and an axon that terminates in the ganglia. So here we have the axon is going to terminate right here in the ganglia. But then the postganglion neuron, their axon is going to extend from this autonomic ganglion to the target cells. Now, unlike the somatic motor neurons, the postganglion fibers of the ANS do not synapse with specific targets, but with a chain of with varicosities stimulating many cells simultaneously. Alright, so we're going to look at the somatic division of the ANS. It's also called the thoracolumnar division because it arises from the thoracic and the lumbar regions of the spinal cord, hence the name. The preganglion neurons are in the lateral horns and nearby regions of the gray matter of the spinal cord. Now their fibers exit by way of the spinal nerves, T1, thoracic 1, and L2, lumbar 2, and then they lead to the sympathetic chain of the ganglia, which are interconnected by longitudinal cords. Now the number of ganglia varies, but usually there are approximately 3 in the thorax. On the cervical we have 11, in the thoracic 4, in the lumbar 4, in the sacral, and 1 in the coccygeal ganglion. Now the nerve cords from the thoracic region ascend to the ganglia in the neck and cords from the lumbar region descend to the sacral coccygeal ganglia. And generally, the head receives the sympathetic output from spinal cord segment T1, the neck from T2, the thoracic and upper limbs from T3 to T6, the abdominal from T7 to T11, and the lower limbs from T12 to L2. So here we have different divisions. In green we have the cervical, the blue region is our thoracic, the pinkish looking region is our lumbar, and the orange is our sacrum. So these outputs, the sympathetic outputs, these are the segments that I was referring to with our T1, which is output from the spinal cord, and of course T2, we're going to have output from the neck to the T2, the thoracic and the upper lumbar, that's from T3, and T3 to T6, and then the abdominal, the abdomen is from T7 to T11, thoracic 7, thoracic 11, and the lower limbs from thoracic 12 to lumbar 2. Those are lumbar 2 and our 7 in our thoracic. Now in the thoracolumnar region, each pair of vertical ganglia is connected to a spinal nerve by 2 branches called the communicating rami. Now the preganglion fibers are small myelinated fibers that travel from the spinal nerves to the ganglia by way of the white communicating ramus. The postganglion fibers, which are unmyelinated, leave the ganglia by way of the gray communicating ramus and extend to the target. So here we have the soma of the preganglion neuron. And these fibers are going to travel from the spinal nerves to the ganglia, which we see right here. And this section here is called the white ramus. And over here is our gray ramus. And these two combined is that communicating rami. over here you see the postsynaptic fibers, which we already stated that they're unmyelinated, and they're going to leave the ganglia. There's one section here, another one here, and they're going to leave the ganglia by the gray communicating ramus, and then exit and then extend to whichever target muscle they're going to go to, whether it's the liver, the spleen, the kidneys, or even the reproductive system. Now, after entering the sympathetic chain, the preganglion fibers may follow only 3 courses. That is, or 3 routes. Now, some end in the ganglion and the synapse immediately with the postganglion neuron. Some travel up and down. They go up and down the chain and the synapse and the ganglia at other levels. And these fibers are the only route by which the ganglia at the cervical, the sacral, and the coccygeal levels will actually receive their input. And some pass through the chain without synapsing and continue as the splenic nerves. Now, the nerve fibers that leave the sympathetic chain by 3 particular routes. It's the spinal nerve route, the sympathetic, and the splenic nerve route. Now, in the spinal nerve route, some postganglion fibers, they're going to exit the ganglia. We have here, they're going to exit the ganglia by way of the gray ramus. They're going to return to the spinal nerve or the subdivisions, and then travel to the rest of the body, to the rest of the way to the particular target. So here it is leaving the ganglia, and they're going to leave it by way of the gray ramus, the gray and white ramus, and then they're going to travel the rest of the way to whichever target muscle that they're going to effect. Well, it's the piloerector muscles or even the blood vessels. In the sympathetic nerve route, the postganglion fibers, they leave by way of the sympathetic nerves that extend to the thoracic viscera. They form a carotid plexus around each carotid artery and extend fibers from there to effectors in the head. Looking at sweat glands. Looking at sweat, salivary, nasal glands, piloerector, blood vessels, and of course dilators of the iris. Now, some fibers form the cardiac nerves to the heart. Now, in the here's just a diagram of the sympathetic nerve route. How we see the gray and white ramus, and of course we see the spinal cord here, and they're going to leave the ganglia, and these are going to be traveling up and down the various up and down the chain and the synapse in the ganglia. And that's our example of the sympathetic nerve route. Here is our splenic nerve route. Now, some fibers that arise from, they're going to arise from the spinal nerves, thoracic 5 and 2, thoracic 12. They're going to pass through the ganglia without synapsing and continue as splenic nerves. And this is going to lead to a second set of ganglia called the collateral. We have here the collateral or the prevertebral ganglia, where they're synapsed with the postganglions. So here's the collateral ganglia, where you're going to have the second set of ganglia meeting, and they're going to synapse here with the postganglion neurons, which will eventually go towards the target muscles, the adrenal gland or the intestines. The collateral ganglia, it contributes to the abdominal aortic plexus, which has three major collateral ganglia: the celiac, the superior mesenteric, and the inferior mesenteric. Now, some authorities are going to use the term solar plexus for celiac and superior mesenteric ganglion, and others are going to use the term celiac ganglion only. Now, the postganglionic fibers, they accompany their arteries and their branches to their target muscles. Alright, so there's no simple one-to-one relationship between the preganglion and the postganglion neurons in the sympathetic division. Now, both neural and convergence, both neuroconvergence and neurodivergence are present. Now, one postsynaptic cell receives a convergent input from a number of different presynaptic cells, and any individual neuron can make divergent connections to many different presynaptic cells. Divergence, it allows one neuron to communicate with many other neurons in the network. Convergence just allows neurons to receive input from many neurons in a network. When dealing with divergence, it predominates, and each preganglionic cell branches and synapses on 10 to 20 postganglionic cells. Now, one preganglionic neuron can excite multiple postganglionic fibers, leading to different target organs, and they have relatively widespread effect. So here we're going to look at the adrenal glands. It's a pair that lays on top of the superior pole of the kidneys. These are adrenal gland. Now, each gland is actually two glands with different functions and embryonic origins. The adrenal cortex, here's a cross-section of our adrenal gland, and we're going to see there is an adrenal cortex and there is an adrenal medulla. The adrenal cortex is the one that's going to secrete our steroid hormones. So we're looking at androgens and aldosterone and our cortisol. The adrenal medulla, which is the inner core, it is essentially a sympathetic ganglion, and the sympathetic nervous system and the adrenal medulla are referred to collectively as a simple sympatho-adrenal system. Now, this adrenal medulla, it consists of modified postganglionic neurons without dendrites or axons, and it's going to secrete hormones into the bloodstream, such as our catecholamines. Two of the three catecholamines. We have 85% epinephrine and 15% norepinephrine. Okay, and they're also used as neurotransmitters. Now, the parasympathetic division of the ANS is also called the craniosacral division because it arises from the brain and the sacral region of the brain of the spinal cord. Its fibers are going to travel in certain cranial and sacral nerves. Now, somas of the preganglionic neurons are in the midbrain, the pons, the medulla oblongata, and segments S2 and S4 of the spinal cord. Now, their long preganglionic fibers, they end in the terminal ganglia in or near the particular target organ. There's not much less neural divergence in the parasympathetic division than in the sympathetic division. We look at neurodivergence. expand on it a little more, it's where we have one preganglic fiber. It's going to reach their target organ, and then it's going to stimulate fewer than 5 postganglion cells. So now we're going to look at the cranial nerves. You have 5 cranial nerves that leave the brain stem. We have the ocular motor nerve, number 3, our CN nerve. CN we're referring to cranial nerve number 3. So CN3 is our ocular motor nerve. CN7 is our facial nerve. Glossopharyngeal nerve is our CN9, and our vagus nerve is our CN10. So hopefully you guys remember how to read Roman numerals. Now for the first one, our CN number 3, this nerve is going to carry parasympathetic fibers that control the lenses and the pupils of the eyes. It has preganglion fibers, and they're going to enter the orbit. So let's find this ocular motor nerve. Here's our preganglion fiber. Our preganglion fiber, the green one here. And those are going to enter the orbit and then terminate at the ciliary ganglia. So here's the ciliary ganglia, and it's right behind the eye. And it's going to synapse here with the postganglion fibers. They're going to enter the eyeball and innervate the ciliary muscle and the pupillar constrictor. Now we have the facial nerve, which is our number, hope you guys remember, number 7. Here we have the facial nerve. The facial nerve is going to carry parasympathetic fibers that are going to regulate the tear glands, the salivary glands, and the nasal glands. Now, after it leaves after the facial nerve emerges from the pons, which we have here, the parasympathetic fiber is going to split and form 2 branches. Now, the upper branch, which we call here, is called the pterygopalatine ganglion, right here at the top. And this one is going to synapse with the postganglion neuron fibers and then continue to the tear glands, nasal glands, and other areas of the oral cavity. The lower branch is it crosses the mid-ear cavity and ends at the submandibular ganglion near the angle of the medulla. The postganglion fibers supply salivary glands in the floor of the mouth. The third cranial nerve, our C9, is our glossopharyngeal nerve. This one carries parasympathetic fibers concerned with just salivation. So here's our glossopharyngeal pharyngeal nerve. When it comes to the preganglion fiber that leaves the nerve, it gets close to its origin, and then it forms the tympanic nerve, which is a continuation crosses the middle ear cavity and ends in the optic ganglion near the foramen oval. Now the postsynaptic nerve of CN9 is going to then follow the trigeminal nerve to the parotid salivary glands. The final cranial nerve, our number 10, is our vagus nerve. This nerve carries about 90% of all parasympathetic preganglion fibers. It travels down the neck and forms 3 networks in the mediastinum of the chest. Right, the cardiac plexus. The cardiac plexus it supplies fibers to the heart. So here's our cardiac plexus. It's going to supply these fibers to our heart. The pulmonary plexus, the extend fibers that are going to occupy the bronchi, the blood vessels, into the lungs. The esophageal plexus, this supplies fibers that are going to regulate swallowing. Okay. Now at the end of the esophagus, these plexuses are going to branch off anteriorly and posteriorly to the vagal trunks, now each of which contain fibers from both the right and left vagus nerves. Now these branches are going to contribute to abdominal aortic plexus. So if you see, here we have the esophageal plexus. At the end of that, here we have our here where the plexus is going to give off to anterior and posterior, so that's in the front and the back vagal trunks, and then each are going to contain these fibers from both the right and left vagus nerves, and they're going to help contribute to the abdominal aortic plexus. Now we have the sympathetic fiber synapse in the aortic plexus, while the parasympathetic fibers are going to pass through and synapse in the terminal ganglia near the abdominal cavity organ. Now the remaining parasympathetic fibers arise from levels S2 to S4 of the spinal cord. These fibers that travel a short distance in the anterior rami of the spinal nerves, and then form pelvic sphincter nerves that lead to the inferior hypogastric plexus. Some fibers synapse here, but some must pass through and travel via plexus nerves to the terminal ganglia in target organs. Now, the digestive tract, it has a nervous system of its own. The enteric system, nervous system, the enteric nervous system, E-N-T-E-R-I-C nervous system. It does not arise from the brainstem or the spinal cord, but it does innervate smooth muscle and glands. It consists of about 100 million neurons embedded in the wall of the digestive tract. It regulates the motility of the esophagus, stomach, and intestines, and the secretion of digestion enzymes and acid. For normal function, these digestive activities also require sympathetic and parasympathetic regulation. So we'll look at Megacolon. It's an insight that you have in your book, Insight 15.1. This talks about Megacolon, and it briefly goes over what it is and what causes it. I dug up a little more information for you guys, so you might need to write it down. The Megacolon, it is an abnormal massive dilation of the bowel, accompanied by abdominal distension and chronic constipation. So here you see right here in this particular diagram, you see that it is distended, and of course it's going to cause chronic constipation. It is also accompanied by paralysis of the peristaltic movements of the bowel. So hopefully peristaltic is dealing with the wave-like movements of feces or food along the particular tract. Now, in extreme cases, the feces are going to consolidate in hard masses inside the colon, and that's called fecalomas. Fecalomas, Fecalomas, which can require surgery to remove. Now, human colon is considered abnormally enlarged if it has a diameter greater than 12 centimeters in the cecum, because a normal one is less than 9 centimeters. Also, if the rectal sigmoid is greater than 6.5 centimeters, and if the ascending colon is greater than 8 centimeters. Now, what are some symptoms? I mentioned one already. You're going to have chronic constipation. It's going to be for a very long duration. You'll have abdominal bloating, abdominal tenderness, and excessive gas, which is called tympany, T-Y-M-P-A-N-Y. We have abdominal pain. You'll have when the physician starts to palpate the area, they'll feel these hard fecal masses. The person will suffer from fever. They'll have a low blood potassium concentration or levels. They'll have tachycardia meaning an increased heart rate, and they also may suffer from shock. But then you have those that are life-threatening complications, and that's when they have colonic gangrene. You have proliferation of the bowel, and of course you have bacteria infection. It also goes on to say that Hirschsprung disease is a cause is one of the causes for from Megacolon, and is usually evident in newborns who fail to have their very first bowel movement, and it affects 4 times as many infant boys as it do as girls. And it's not the only cause of Megacolon, but we can get it from, depending on maybe a third world country where you have kissing bugs that may be transmitted, that may transmit parasites to the humans. And then of course with that bite it can destroy the autonomic ganglion of the enteric nervous system, leading to gangrene in the megacolon. Alright, so how can different autonomic neurons have different effects, such as constricting some blood vessels but dilating others? There's 2 fundamental reasons. We have the parasympathetic and the parasympathetic fibers. They'll secrete different neurons. Now the target cells, they respond to some neurotransmitter differently depending on the type of the receptor that they have for it. For example, dopamine. Dopamine can be used to increase sodium secretion by the kidneys, but it also can vasodilate the blood vessels. Now, acetylcholine and or norepinephrine are 2 major neurotransmitters of the ANS. And why is that? It's because they are secreted by all autonomic fibers. Now, acetylcholine is secreted by the preganglion neurons in both divisions and by the postganglion neurons of the parasympathetic division and a few sympathetic postganglion neurons. And the acetylcholine was discovered by Otto Louis. Now, a nerve fiber that secretes acetylcholine is called a cholinergic fiber, and any fiber that binds to it is called a cholinergic receptor. So we have the cholinergic fiber, which is the fiber that will secrete the acetylcholine, and we have the receptor, is where the is the receptor that it binds to. The two categories of cholinergic receptors are muscarinic receptors and nicotinic receptors. The very first one, the muscarinic receptors, are named for muscarine, a mushroom toxin used in their discovery. Now, some muscarine receptors, they lead to excitation, and others lead to inhibition. They are involved with second messenger systems. The nicotinic receptors, they're named after nicotine, a type of toxin, a botanical toxin. They occur at all synapses in the autonomic ganglia, and the binding of the acetylcholine to the nicotinic receptor is always excitatory. So they open the ligand-gated ion channels to produce excitatory postsynaptic potentials. The norepinephrine is secreted by nearly all the sympathetic postganglion neurons. They're also called the adrenogenic fibers. Now, nerve fibers that secrete norepinephrine are called adrenergic fibers, and the receptors are called adrenergic receptors. Now, there are two types of those receptors. You have a beta and you have an alpha. The alpha ones are usually have excitatory effects, but not always. There are like two subclasses of the alpha. There's an alpha 1 receptor, and you have an alpha 2. The alpha 1 receptor suppresses the synthesis of CAMP, which is our cyclic adenosine monophosphate, and whereas the alpha 2 receptors, they're going to employ calcium ions as a second messenger. Now, our beta receptors, they're usually inhibitory, but not always. There are also two subclasses. You have a beta 1 and a beta 2, and they're going to mediate different effects, but both act through the cyclic AMP. So here we have an example of our parasympathetic nerve fiber, and we have our sympathetic nerve fiber here. So you can see in the diagram that with the adrenogenic fiber, they're going to be responsible for excitation and releasing of the norepinephrine. Here we have the norepinephrine ready for the particular target cell. But in the colonic, they're going to be releasing acetylcholine. Okay. Here for the particular target cell. So the receptors would be the cholinergic receptor, and of course the fiber is our cholinergic fiber, and that's the fiber that's going to release the acetylcholine for the particular receptors. Now, the autonomic effects on the glandular secretion are often an indirect result of their effect on blood vessels. Either going to increase or decrease in blood flow affects the ganglion secretion accordingly. Now, the sympathetic effects tend to last longer than the parasympathetic effects. You have the acetylcholine from the parasympathetic fiber is quickly broken down by the acetylcholine esterase. Let's see if I can go back to the other slide for you guys. You can see what's going on here. So the acetylcholine from the parasympathetic fiber is quickly broken down by the acetylcholine esterase, and its effects last only a few seconds. And the norepinephrine from the sympathetic fiber has a number of fates. Some is reabsorbed by the nerve fiber, where it is reused or is broken down by the monoamine oxidase, MAO. Some are going to diffuse into adjacent tissues, where it is degraded by COMT. This is catechol methyltransferase. Much of it is passed into the bloodstream, where it circulates through the body and has a prolonged effect. Now, the ANS also employs other neurotransmitters. Many fibers, they're going to secrete neuropeptides that modulate acetylcholine and the norepinephrine. The sympathetic fibers, they may secrete substance P, somatostatin, neurotensin. They're going to secrete those. And some parasympathetic fibers, they're going to release nitric oxide, which allows blood vessels to dilate. Now, most visceral have dual innervation. That is that they receive nerve fibers from both sympathetic and parasympathetic divisions. These divisions may have either antagonistic or cooperative effects on a single organ. Okay, I kind of jumped ahead of myself just a little bit, but before I go on or go over that, let me deal with this slide here, slide 1533. Now, the autonomic effects on the glandular secretion are often an indirect result of their effects on the blood vessels. So they're going to have this dual innervation. Okay, you're going to have vasodilation, but you're going to increase blood flow and increase secretion. And then your vasoconstriction, they're going to decrease blood flow or decrease secretion. Now, the sympathetic effects tend to last longer, like I mentioned earlier, than the parasympathetic effects. And the acetylcholine are going to be released by the parasympathetic and is broken down quickly at the synapse. And then the NE, which is our norepinephrine, they are broken down. They are released by the parasympathetics, and they're going to be reabsorbed by the nerve, diffusing to the adjacent tissues, and some of them passed into the bloodstream. Now, what are the subdivisions we went over of the ANS? They are the parasympathetic. The sympathetic is our flight or fight, and our parasympathetic, which deals with rest and digestion. Now, let's look at a few organs in the body and the responses when it comes to sympathetic and parasympathetic. In the eye, well, the iris, I say in the iris, but the iris, when we look at the iris, with a sympathetic type of response, what will happen to the iris? Is it going to dilate or is it going to constrict? And what's going to happen with a parasympathetic response? With a sympathetic response, we're going to have pupil dilation, parasympathetic constriction. For their salivary glands, sympathetic and parasympathetic, you have thick saliva production, and then you have thin saliva production. With heart, of course, with the sympathetic, as I said, is dealing with fire flight. You're going to have an increase in heart rate and force, and in the force and an opposite reaction with our parasympathetic. Our lungs, they're going to have bronchodilation. So you're going to have the bronchus going to be open a lot more, just to ensure we have sufficient airflow to the proper bronchi. And parasympathetic is going to be bronchoconstriction. With the skin, what do you think will happen? We'll have vasoconstriction for our sympathetic and vasodilation for our parasympathetic. For the stomach, what do you think will happen? We'll have decreased peristalsis, and with our parasympathetic, we'll have gastric secretion of our gastric juices. With our liver, we have an increased conversion of glycogen to glucose. So if you're running away, of course you're going to need more glucose to be converted to ATP so that you can get away as fast as you want to get away. So that glycogen, which is stored in the liver, needs to be converted to glucose. And for our parasympathetic, we have glycogen synthesis. Our kidneys, we're going to have a decrease in urine output, but in our parasympathetic, there's no effect. And then penile and clitoral erection. For sympathetic, there is no effect at all. In our parasympathetic, you'll have stimulation. Now with dural innervation. Now most viscera have dural innervation. That is, that they're going to receive nerve fibers from both sympathetic and parasympathetic divisions. These divisions may have either antagonistic or cooperative effects on a single organ. Now we look at the antagonistic effects. They are going to oppose each other. For example, the sympathetic division is going to speed up the heart, but the parasympathetic is going to slow it down. In some cases, these effects are due to dual innervation on the same effector cells, as in the heart. In other cases, each division are going to innervate different effector cells having an opposite effect. For example, the sympathetic fibers are going to innervate the palatory dilator, and the parasympathetic fibers are going to innervate the constrictor. Now with the cooperative effects, that occurs when the two divisions act on different effectors to produce a unified overall effect. For example, in salivation, you have parasympathetic fibers that are going to stimulate the serous cells of the glands, while sympathetic fibers are going to stimulate mucous cells of the same gland. Now unequal influence also occurs, such as in the wall and the digestive tract, where the parasympathetic fibers predominate, or the ventricles of the heart, where the sympathetic input predominates. Alright, so let's look at the antagonistic effects again. We said it's going to oppose each other, correct? So when they oppose each other, they're going to exert dual innervation of the same effector cells. So what was the example I gave? We gave a heart rate will decrease with the parasympathetic division, but then with a sympathetic division, what's going to happen with the heart rate? It will increase. Now exerted because on each division is going to innervate different cells. So that's in certain cases that have been acting on different cells, having an opposite effect. So you have pupillary dilator muscles, which are sympathetic. And they're going to dilate right here. She's opening all the wide, dilate the pupils. But then you have the constrictor pupillae. Those are going to constrict the pupils. Those are parasympathetic action. And go over cooperative again. Cooperative effects is when two divisions, they act on different effectors to produce a unified effect. For example, you have the parasympathetics. They're going to increase the salivary serous cell secretion. So you're going to have more saliva coming from this particular cell. And the sympathetic, they're going to increase saliva or mucus from the mucus cells. So two different divisions working together so that we can accomplish a particular goal. Such as in the digestion, you're going with when we get to the digestive chapter. I don't remember what chapter that is, but when we get to digestion, we realize that digestion takes place in the oral cavity. You have the salivation occurring to help moisten the food and breaking the chemicals within it are going to break it down. And that's what we're talking about with with a cooperative effect. Both the parasympathetic and the sympathetic are being used to secrete the serous or the saliva, to increase saliva from two different cells, the serous cell and the mucus cell, so that we have saliva to help with the digestion and the moistening of the food. And here's just an example that your book has on pupil dilation and as well as pupil constriction. And this is dealing with dual innervation. So would it be a cooperative effect or would it be an antagonistic effect? This would definitely be an antagonistic effect because you're having the opposite reaction occurring from the two different systems, or two different effects, the sympathetic and the parasympathetic. The parasympathetic is causing pupil constriction, and the sympathetic is causing pupil dilation. Now, in some cases, the autonomic nervous system can produce opposing effects without dual innervation. So, some of them we're just going to receive sympathetic fibers. Now, the adrenal medulla, the erector pili muscles, the sweat glands, and many blood vessels, they're only going to receive, this is just a few examples of those fibers that are just going to receive sympathetic fibers. The most significant example is the regulation of blood pressure and the routes of blood flow. Now, sympathetic fibers to the blood vessels, they're going to keep the blood vessels in a state of partial constriction called vasomotor tone. Now, he will have an increase in firing rate, constricts the vessel by increasing smooth muscle contraction. It's going to decrease in firing, which is going to allow the smooth muscle to relax and the blood and the vessels to dilate. So your increase in firing will cause vasoconstriction, and a decrease in firing will cause vasodilation. Now, sympathetic control of the vasomotor tone can shift blood flow from one organ to another, such as increased dilation of the arteries, of the arteries to the skeletal muscles and the heart under any type of emergency, stress, or exercise. At the same time, it's going to constrict the arteries to the gastrointestinal and the urinary system, as they are not essentially under such conditions. So under stress, we're going to have blood vessels to the muscles and to the heart. They're going to dilate, and that's to make sure you have sufficient blood flow to the to the active muscles, as you would say. Then, of course, to the skin itself, you have a vasoconstriction, because basically you don't need the skin at that point in time. Now, don't forget, when they say vasoconstriction, not saying completely shut off. It's just closed slightly, so you're going to still have blood flow to those areas, just not as much as before. Now the sympathetic division, it prioritizes blood vessels to the skeletal muscle and in the heart in case of emergency, like I stated. Now blood vessels to the skin, what are they going to do? Said it on the last slide. What's going to happen with that? We're going to have vasoconstriction, and that's to make sure we have minimal bleeding if the injury occurs during stress or during exercise. Now, in spite of its name, the ANS is not independent. All of its output obviously is going to come from the CNS, and it is influenced by other levels of the nervous system. The cerebral cortex, for example, it influences the ANS through thoughts and motions such as anger, fear, and desire, just to name a few. Now, the limbic system is involved in many emotional responses and has extensive connections with the hypothalamus. The limbic system thus provides a pathway connecting sensory mental experiences with the autonomic nervous system. The major control center of the visceral motor center is the hypothalamus. This region contains many nuclei for primitive functions such as hunger, thirst, emotions, and sexuality. Output from the hypothalamus, it travels to the nuclei and many caudal regions of the brainstem, and from there to the cranial nerves and the sympathetic regions in the spinal cord. Now, the ANS is regulated also, just a continuation of that. We have the midbrain, pons, and the medulla oblongata. They're going to house several autonomic nuclei, of which many belong to the reticular formation, which extends from the medulla to the hypothalamus. So they're going to regulate swallowing, bladder control, salivation, also sweating. The autonomic reflexes such as defecation, micturition, erection, ejaculation are integrated in the spinal cord. The brain can inhibit defecation and urination consciously, but if the spinal cord is severed, spinal reflexes alone control these functions. So here we're going to deal with, just touch on neuropharmacology. What is neuropharmacology? The study of effects on the nervous, the study of drug effects on the nervous system. Now we have the, sorry for my pronunciation, my sympathomimics, I'm sorry. It enhances the sympathetic activity. It's going to mimic the effects of transmitter substances of the sympathetic nervous system as catecholamines, and those are norepinephrine, epinephrine, and our dopamine. They're going to act at the post-ganglion sympathetic terminal, either going to directly activate postsynaptic receptors, blocking breakdown, and of course reuptake. They may stimulate production and the release of catecholamines. They will stimulate receptors or increase norepinephrine release, such as cold medicines that will dilate the bronchioles or constrict nasal blood vessels, and are used to treat cardiac arrest, hypertension, or even delay premature labor. Now to continue with my sympathomimetics, we have those that are that act directly on the cause or act indirectly. We have our adrenergic receptor agonists, And these are just a few that I pulled out of doing some extra research to put in here for you guys, especially for those that are going into nursing. These are very important drugs that you have to know or should know, that you will definitely see later. So this last one here, the butamine, they're going to treat heart failure and any cardiogenic shock. And we have some that are going to decrease the cardiac, the bradycardia, which is slow heart rate. Some will treat the same one, also treat heart block and as well as asthma. So those are going to act directly on the problem. Some are going to act indirectly are those norepinephrine and our dopamine transmitter blockers, which are amphetamines and cocaine. They act by blocking and reversing the norepinephrine transmitter activity. So they're just going to block the receptors. They're not actually going to treat the problem. Now the third one would be second one is our sympatholetics, and they're going to suppress the sympathetic activity. So they're going to suppress all the exciting things, the fight or the flight. So they're going to inhibit the postganglionic functions of the SNS, the sympathetic nervous system. They block receptors or inhibit the norepinephrine release. So beta blockers, which hopefully everybody has heard of beta blockers before. They're going to reduce the high blood pressure, interfering with the effects of epinephrine and or norepinephrine on the heart and on the blood vessels. You have alpha blockers, which are used to treat anxiety and of course panic. Clonidine, which is used to clonidine, and this other one here, guanfacine, they're used to help decrease the release of this norepinephrine in the brain. Now our parasympathomimetics, they enhance activity, while parasympatholetics are going to suppress activity. Now many drugs also act as neurotransmitters in the CNS, such as Prozac, and they're there to block the retake of serotonin, to prolonging its mood elevating effects. Now we have caffeine. Caffeine is an example of the very last one we're talking about. Caffeine, it competes with adenosine by binding to its receptors. And it increases the alertness, as you see right here. Increases alertness, increases memory retention, decreases the risk of heart disease, but that's only in moderation. But what's the side effects? We have anxiety, increased vasoconstriction and blood pressure, reduced control of fine motor movement, and stimulation of urination. Now you may ask, how is it possible that it's going to decrease your risk of heart disease, but then the side effect will be to increase vasoconstriction and blood pressure? Just remember, everything in moderation. Some doctors are telling heart patients that it's okay to drink a little bit of alcohol, but then we understand the effects of alcohol on the blood and on our cardiac patients. So just one glass a week, or a small glass of wine a day is okay, when it's really not in the long run. So if you have any questions pertaining to this chapter, you know what to do. Go to the discussion board and Blackboard and post any questions that you may have concerning this chapter.